Expertgruppen för biståndsanalys, EBA, är en statlig kommitté som oberoende analyserar och utvärderar svenskt internationellt bistånd för att det ska kunna förbättras och utvecklas. EBA har 10 ledamöter med kompetenser från olika biståndsområden och ett kansli som verkställer besluten. Förutom våra rapporter så ordnar vi seminarier, workshops och möten mellan olika parter. Varje år sammanfattar EBA sin verksamhet i årsberättelsen Biståndsanalys. Den kan beställas från kansliet eller laddas ner på eba.se. EBA har ett oberoende i relation till uppdragsgivaren regeringen, liksom i relation till vad som utvärderas, samt till de rapportförfattare som anlitas. Rapportförfattarna ansvarar själva för slutsatser och rekommendationer i sina studier. Allt vi producerar som rapporter, seminarier och vår podcast EBA-podden finns tillgängligt på vår hemsida.
Good morning and welcome to today's webinar on improving healthcare in conflict zones. Evidence from Palestine, Colombia and Red Cross hospitals. This webinar is organized by the Expert Group for AIDS Studies, EBA, and my name is Johan Shah. I'm the Vice Chair of EBA. Today's webinar is part of our series on development dissertation briefs, which is an opportunity for people who have recently presented their dissertations and theses and become PhDs to present their research, their findings to a broader interested Swedish audience. And of course the purpose of this series of DDB presentations is to share, provide knowledge for the government and for other stakeholders and interested parties. And of course we are trying to focus on research that is of interest and relevance for Swedish development cooperation. And as with all reports published by EBA, the authors of these development dissertation briefs are solely responsible for the analysis and recommendations that they provide. Today our focus is on health services and health systems in a very specific context, namely the context of armed conflict. And we are particularly going to discuss and look at 3 perspectives. The first one being, well, this is not the order they will come in, but the first one is on the double burden that health systems have when they have to contend with the sort of normal burden of non-communicable diseases, while also being part of or serving in a context of conflict, having to do sort of war-related health services as well. We are also going to look at the sort of gender dimension of health services in conflict, and particularly on the aspect of sexual and reproductive health and rights. And we're also going to learn about methods and resource use in war surgery. For us, I think this is the first time the EBA sort of presents this kind of focus and this kind of context. And of course it is sadly timely as we have the war in Ukraine as the sort of background and backdrop to what we're going to hear today. So first of all, we'll listen to Signe Svalfors, who will present her brief on the effects of armed conflict on women's sexual and reproductive health and rights in Colombia. After that, we'll listen to Marwan Mosleh, who finds himself in Gaza, who will present his research about the handling of war injuries and non-communicable diseases in the Palestinian health system, and specifically in Gaza. And finally, we'll listen to Måns Murbeck, who will present his research on surgery in armed conflicts and how the use of resources can be improved in such contexts. We are very pleased and extremely fortunate in having someone who is exceptionally qualified to give comments and sort of discuss these 3 dissertations. This is Åsa Molde, who is a surgeon with a very long experience of working in the kinds of contexts that we are going to discuss today. She did her first assignment in that kind of environment in 1990, working for the Red Cross in Ethiopia. And she has then worked for the WHO in Bosnia during the Balkan conflict, and also for the International Committee of the Red Cross in, among other countries, Afghanistan, Pakistan, Angola, and Sierra Leone. She's also done other sort of traditional core assignments that are part of the mandate of the ICRC in visiting prisoners of war and also working on family reunification. The audience, you are welcome and feel free to use our tags if you post anything on social media, and you're most welcome to ask questions in the Q&A function on the Zoom. There's no chat function available today, so please use the Q&A function. And let me then first give the floor and the microphone to Signe Svalfors. So she defended her thesis, Bodies and Battlefields, Sexual and Reproductive Health and Rights in the Colombian Armed Conflict. And this was a thesis in the sort of topic of demography at the Department of Sociology at Stockholm University. And this happened in November last year. So please, Signe, the microphone is yours.
Thank you very much, and thank you to EBA for hosting this seminar and to the audience for being here today. So, as of yesterday, you will find me as a postdoctoral fellow at the Department of Global Public Health at the Karolinska Institute, and this work is based on my thesis from Stockholm University. So to start, I'd like to take you back to 2016, when the Colombian government and the left-wing guerrilla FARC met in Havana in Cuba with a goal to sign a set of peace accords to end the violent conflict after more than 50 years. This peace process was internationally celebrated for uniquely and unprecedentedly acknowledging women's wartime experiences, not least in terms of sexual and reproductive health and rights. And around this time, the Swedish government also became involved in the peace process within the framework of the Feminist Foreign Policy Agenda. The then Minister for International Development Cooperation, Isabella Lövin, for example, called the Havana Agreement the world's first gender-equal peace accords. And this led me to explore how Colombia's armed conflict has affected women's sexual and reproductive health and rights. So the key concept of the dissertation was sexual and reproductive health and rights, which I will abbreviate SRHR for short. And this emphasizes the right for all individuals to enjoy a state of physical, mental, and social well-being in relation to all aspects of sexual and reproductive health. So why is this topic worth exploring in the context of conflict? Well, first of all, even though there have been many progressive changes in SRHR over the last century, this trend isn't always sustained or evenly distributed. Women living in war zones may be particularly vulnerable to sexual and reproductive health problems, such as pregnancy-related mortality and morbidity that could have been prevented, a lack of access to health care, and conflict-related sexual violence that seriously undermines women's safety, health, and dignity. And when talking about conflict, it is clear that every society is always affected by war in its own unique way. So in Colombia, the history of conflict dates back to the mid-20th century and involves the government, paramilitary groups, organized crime groups, and left-wing guerrillas such as the FARC that I mentioned, and other groups such as the ELN. And we have a set of non-state armed groups that have ruled large rural areas and de facto replaced many of the state's functions in those areas, including monopoly of violence and sometimes also healthcare provision. As for the research design, In this thesis, I used multi-level quantitative analyses, statistical analyses of data collected from the demographic and health surveys that have been conducted in Colombia every fifth year from 1990 to 2016, as well as conflict data from the Uppsala Conflict Data Program. I also collected expert interviews with stakeholders or key interviewees in peace and women's health and rights in Colombia. And these respondents can be seen as a panel with several decades of cumulative experience in SRHR, peace building, and women's health and rights in Colombia. This thesis is what we call a compilation thesis. So it consists of 4 separate articles that you can see the titles of here. The first one is still under review with an academic journal, and the 3 latter ones are published, so those you can find online. So to start with the first paper then, here I explore how matters related to women's bodies, sexuality, and reproduction have become politicized in the context of the Colombian conflict, and this is based on the interviews I collected with experts. And here my analysis shows that multiple actors involved in conflict have used women's bodies, reproductive capacities, and health as strategic instruments in military agendas. So according to the interviewees, armed actors have deliberately obstructed women's access to care by hindering them from leaving an area that they control to go to a healthcare facility, for example, to access contraceptive services or abortion services. Healthcare personnel have been purposefully targeted by armed groups, ranging from being forced to serve illicit groups with healthcare, being robbed or kidnapped, or being restricted from entering an area under the group's control. The impact of conflict on SRHR has not only been purposeful in terms of targeted destruction, but also collateral due to the overall decay seen in war. So for instance, conflict has made access to reproductive healthcare services, such as contraception, less reliable in areas characterized by geographic inequality, which makes already marginalized women particularly affected. As shipments turn irregular and unreliable because of transportation issues related to remoteness and strategic roadblocks, basic commodities become scarce. And combined with increased poverty following economic collapses related to war and a reluctance among healthcare professionals to work in those conflict-affected areas, women face many difficulties in accessing care. Another politicization of women's bodies in the war context that is often discussed is the use of sexual violence, which in Colombia has taken place both as a military strategy to combat enemies and destroy communities, but also as crimes of opportunity and an amplification of patriarchal gender norms. And women who are victimized of sexual violence are often encouraged to bear the pregnancy to term and sometimes prevented from leaving an area under an armed group's control to access abortion, which according to the experts that I interviewed can be characterized as forced maternity. So moving on then to the second study about conflict and contraception in Colombia. Here, my co-author Sunny Billingsley and I examined the effect of local violence on women's use of modern contraception during the period 1990 to 2016. And here we found that modern contraceptive use overall decreased depending on the intensity of conflict over time and space. We found that a small part of the relationship could be explained by an increase in women's desire to have children soon, which could reflect uncertainty about losing a partner due to the high homicide rate among younger men in Colombia. But it's also very likely that women's access to contraception decreased due to conflict. We also examined other potential factors such as employment, sexual activity, and violence in intimate partnerships, but none of those factors played a role in this relationship. We also found no difference in the risk of using traditional, short, or long-acting reversible contraception, only an increase in contraceptive non-use. So it seems that demand and overall supply do matter in shaping women's contraceptive use, but it doesn't matter which type of method is available at any given moment, or that some methods are more available than others. And I will move on to talk about the third study, which looked specifically at women's uptake of sterilization during 1990 to 2016. And this was based on mixed methods, so both survey data, conflict data, and the expert interviews. Sterilization is the only method of contraception that reflects a definitive stop to women's childbearing. And I examined 4 theoretically motivated hypotheses about whether women's uptake of sterilization increased or decreased, and whether any changes were voluntary or forced. And these analyses show that local conflict was linked to an increase in sterilization uptake overall. So sterilization was more common among more affluent women who are most likely to be able to make autonomous reproductive choices. The interviews suggested that women may choose sterilization when reversible methods become less available in conflict. Since sterilization is a relatively available contraceptive option in Colombia, since 20% of the population are sterilized, my conclusion was that it may represent a risk aversion strategy for women who have achieved their fertility goals when other aspects of life turn more uncertain during war. And then finally, the fourth study, here I examined the effect of armed conflict on women's experiences of intimate partner violence during 2004 to 2016. And this analysis showed that exposure to conflict is linked to an increased risk of women being exposed to emotional, physical, and sexual violence perpetrated by their intimate partner or ex-partner. But I did not find any evidence that women would be more acceptant of intimate partner violence due to conflict. Among the women who had experienced intimate partner violence, conflict related to an increased probability of being in a relationship, and this may reflect that women stay in violent relationships since conflict may normalize violence, or that conflict increases women's unwillingness to leave these relationships even though they are violent. So these findings suggest that armed conflict is not only indirectly extremely harmful to women by increasing their risk of several forms of intimate partner violence, but also exacerbates the vulnerability of women who are already victimized. The main political implication of this article is that the focus of the Havana Peace Agreement on sexual violence was not sufficient to address all forms of gender-based violence in Colombia's armed conflict. A one-sided focus on public violence ignores the hidden victims of war in the private sphere. And then I'll move on to some overall conclusions of the thesis. So first of all, my dissertation shows how the consequences of armed conflict for women's sexual and reproductive health and rights are multifaceted. And conflict increases insecurity for women in ways that have previously been somewhat overlooked. So for example, when it comes to a lack of access to healthcare, increased risks of violence in intimate partnerships, and sexual violence that is perpetrated both as military strategies and opportunistic crimes. And then finally, I will talk something about policy recommendations. So the dissertation points to the need to increase access to sexual and reproductive health care services for conflict-affected women, including a broad range of contraception, access to legal and safe abortion, as well as care and legal support for women who have been victimized of multiple forms of gender-based violence. Efforts should focus on rural areas with high levels of conflict and limited access to healthcare, as well as include women's perspectives and experiences to develop interventions. So Colombia is now at a critical moment in terms of violence prevention and peace building, which requires that SRHR, reproductive matters, and gender equality are not overlooked or overshadowed. And this demands significant efforts from policymakers, service providers, as well as academic research. But on the bright side, the current process of peace and reconciliation has indeed opened a window of opportunity for sexual and reproductive health and rights. And with that, I'd like to thank you for your attention, and I welcome comments and questions. Thank you.
Thank you very much, Signe, for bringing us to Colombia and bringing us into this very specific and sort of continuously evolving context. Thank you. We are now going to move to Gaza and listen to Marwan Mosleh, who defended his thesis on non-communicable diseases and war injuries in Palestine, burden, incidence, and management in the health system. And this was done at the Department of Health Sciences at the Mid-Sweden University in October 2020. So please, Marwan, the floor and the microphone is yours.
Okay, thank you so much for giving me this opportunity to present my work regarding my thesis work at the Mid-Sweden University entitled Non-Communicable Diseases and War Injuries in Palestine, Burden, Incidence, and Management in the Health System. Okay. Okay. My thesis work is based on four published papers. The first one about the burden of non-communicable diseases. The second one on the burden of war injury in the Gaza Strip. And the third paper about non-communicable disease and war injury management in the Palestinian health system in the Gaza Strip. And the last one about the barriers for managing and delivery of care to war injury survivor or patient with non-communicable disease in Gaza Strip. My thesis work used mixed methods, a combination of quantitative along with qualitative methods. The first two papers used the quantitative methods, and the third and fourth one used qualitative methods. You know that Gaza Strip is the context of long protracted armed conflicts and wars, and you know that the Gaza Strip is experienced four wars in 2008, 10, and 12, and the last one in 2014. You know that the justification of conducting my work that this field is largely neglected in health research, and rarely the researchers focus on this field of work. The overall aim of this study is to analyze, describe the burden, incidence, and management of non-communicable disease and war injuries in Palestine, especially in the Gaza Strip. As I said before, the specific objectives of my thesis work address the burden of non-communicable disease and war injuries, and addressing the management of the two diseases in the Palestinian health system, and the last one address the main barriers to managing and delivery of care to non-communicable diseases and patients with war injuries. As I said before, the methodology used mixed methods, a quantitative along with a qualitative. Research population. In study one, we used two data sets. The first one from the health survey. We used the morbidity data from the health survey conducted in the Gaza Strip. And the second set of data used the mortality data from the Palestinian Ministry of Health annual report. In study two, we used the injuries data from the Gaza War 2014. And the third and fourth paper, we used the data collected from a qualitative interview and focus group discussions. Of course, the research setting was in Palestine, mainly in the Gaza Strip. In study three, we conducted 4 focus group strategy among the healthcare providers, mainly the physicians, surgeons, and head nurses. In study 4, we conducted in-depth interviews with policymakers and the patients. The patient, you know that we conducted the interview with the war-injured patient and non-communicable disease patients. The data analysis for study one, we used the World Health Organization Microsoft Excel spreadsheet templates. This is special sheets to analyze the burden of disability. The data using SPSS software. I think. Okay, for study 3, we use the manifest content analysis to analyze the focus group discussion data. And for study 4, we used thematic driven analysis to analyze the qualitative collected data. The summary of main result for paper 1, the burden of non-communicable disease in the Palestinian health system. The disability adjusted life years, which were calculated due to non-communicable disease in Palestine, were 60 births per 1,000 and 57 per 1,000 in the West Bank and the Gaza Strip, respectively. With each one daily is thought of as being one lost year of optimal healthy life. The heart disease were found to be the greatest disease overburden in terms of deaths in Palestine in 2010. And regarding the paper 2, we analyze and characterize the incidence and patterns of injuries associated with war in the Gaza Strip 2014. You know that a study showed that the incidence of war-related injuries was higher among males than females, resulting in a male-female ratio of 3 to 1.1. The majority of war-injured survivors were adults, the majority were single, and the rest were married, divorced, or widowed. The overall average incidence of war injuries was 6.4 per 1,000, reported as in all regions. The largest proportion of war injuries were located in the upper body. Almost half of war-injured survivors underwent debridement and wound management, whereas 19.3% had surgical intervention of the upper body, including head, face, neck, chest, spine, pelvis, or extremities. Severity of war injury and disability by age, sex, and the place of residence. Of course, the study indicated that severity of injury and disability differed significantly between male and female war-injured survivors. There was also a significant difference in severity of injuries and disability among war-injured survivors according to their place of residence across all Gaza provinces. Regarding paper 3, in paper 3, we address the perceptions of non-communicable disease and war injuries management in the Gaza Strip. In this paper, we used manifest content analysis. 4 themes emerged in this paper. The first theme regarding the functioning of health care systems. Theme 2, system-related challenges. Theme 3, patient-related challenges. And the last theme 4, strategies and actions to navigating the challenges and improving of care. I will not go through all of them, but we can discuss later after finishing the presentation. We had sub-themes for each main themes, but I will go directly to paper 4. For paper 4, in this in this papers, we address the barriers from the policymakers and patient perspectives. From the perspective of barriers by policymakers, 5 main themes were emerged. The first one, organizational structural barriers, availability related barriers, personnel related barriers, financial and political barriers, and communication barriers. From the perspective of barriers by patient, 4 main themes were emerged. The first one, organization barriers regarding the health system barriers, availability, financial and socio-economic barriers, physical and psychological barriers, and the last one is regarding communication barriers. In this table, you see that we describe all themes and sub-themes. And now we can discuss and to use the time effectively. Thank you so much for hearing.
Yeah, man. Thank you, Marwan. I think the last 2 slides or so with your main conclusions
yes.
were a bit quick. Could you perhaps just show us those 2 again?
Yes, sorry. Okay. I missed them, yeah. I can...
Because you've made some overall conclusions on the basis
of...
exactly.
Yeah, I missed them, yeah. Please, if you can, yeah.
Yeah, so that's paper 4, and then you had some...
Conclusion, yeah. Yeah, I think, okay.
Okay. You completed.
Okay. I can, okay.
Okay, yeah, perhaps you could just very quickly tell us about these main conclusions.
Okay. The main conclusion of my study, the first one, many of deaths were estimated due to non-communicable disease in this study. Heart disease were the main overburden of non-communicable disease. Fundamental changes and comprehensive reforms are needed to the health system of Palestinian health system. The quality of care was suboptimal and unsatisfactory. The study illustrated the suboptimal task sharing and poor collaboration among the governmental and private health sector and different stakeholders. The study illustrated that non-use of updated clinical guidelines, I mean for non-communicable disease and war injury management, and the health surveillance system using ICD codes is necessary to improve the health care in the Palestinian health system. Those are the main point in my conclusion for my studies. Thank you so much.
Thank you very much, Marwan. So this is we are seeing a health system which is extremely challenged and not well functioning from the beginning, which is then
exactly.
has to deal with the additional burden of
Yeah.
war injuries and conflict. So thank you. I think this is a very important context to bring with us. As we move on now to look at the sort of specifics of the war surgery part of the health system, and we're going to listen to Måns Murbeck, and he defended the thesis on surgery in armed conflicts, predicting surgical treatment needs and improving resource use in resource-constrained settings. And this was done in December last year at the Department of Surgery in Norrköping and the Department of Biomedical and Clinical Studies at Linköping University. So please, Måns, the floor and the mic is yours.
Thank you so much, and good morning, everyone. And I would like to thank the EBA for the kind invitation to do this presentation on my thesis. And I'd just like to mention that my main supervisor was Associate Professor Peter Anderson. So my dissertation or my thesis dealt with an area which is quite complex, of course, and this is how you optimize the use of surgical resources where the resources are limited to begin with. So I would like to start with just giving you a brief background, create a setting for the thesis, and then I'll go through three or four papers that were included in the thesis. So let's start off with the background. Okay, so on this slide you see two maps. The map on the left-hand side, which is labeled A, is from an article that was published by Paul Farmer in 2015. And what this map demonstrates is the proportion of the population that have access to surgery when they need it. And the more red a country is, the poorer the access to surgery is. And the map on the right-hand side, which is labeled B, is from the Uppsala Conflict Data Program. And the red areas indicates where there is ongoing armed conflicts. And the map is from 2018. And if you compare these maps, you can see that countries where the access to surgery is poor is also countries where there's ongoing armed conflicts, with exceptions, of course. So this is really the essence of why I think my thesis is important, is that you have countries where the access to surgery is poor, and then you add on a armed conflict. And so the interesting question is what happens to the access of surgery? And so what I wanted to understand is basically the relationship between how people are injured, what they're injured from, and what treatment they need, what surgical treatment they need. And I also wanted to explore if there were tools or factors that could be used to predict what their surgical resource needs would be. So for this study, I used data from the ICRC, the International Committee of the Red Cross, and they were very generous to provide me with the data. And the data comes from 3 different ICRC hospitals. 2 were located in the northwestern area of Pakistan, close to the border of Afghanistan. And these hospitals, they treated patients that were injured in the conflict in Afghanistan, and also in the conflict at the border of Afghanistan and Pakistan, called the Durran Line. And I also had data from ICRC's hospital in Goma, which is located in the Democratic Republic of the Congo. And this hospital treated patients that were injured in the Kivu conflict. There's a lot of things to say about these conflicts, but there's one main difference which is interesting for my thesis, and it is that there's a bit of a difference in what kind of weapons that were used in these conflicts. So for the conflict in Afghanistan and at the border of Afghanistan and Pakistan, this conflict was characterized by the use of more heavy weapons. And these weapons are called indiscriminate weapons, and generally missiles, mortars, aerial bombing, that kind of weapons are considered indiscriminate. And what it means is that if you use this weapon, you can't limit the impact the weapon will have. So in the Kivu conflict, the more lighter armor were used, like knives and rifles and that kind of weapons. And I'll get back to that in my third paper, why this is an important difference. So this slide is just to give you an idea for the capabilities of these three ICRC hospitals. They had basically the same setup and the same capabilities. And it's important to mention when you talk about humanitarian organizations, and in particular ICRC, that the hospital staff, they did not ask if the patients were combatants or civilians. The hospitals provided all care for free, and they all only treated weapon-related injuries at these hospitals. So that was the background. So let's dive into the papers. So for the first paper, this is available by open access, by the way. I wanted to understand the relationship I mentioned earlier with what kind of weapons that are used, how people are injured, and what kind of surgical treatment they need. And I wanted to find out this in a group that is strictly civilian, and this is can be a bit tricky in these settings because, like I mentioned earlier, that the hospital staff doesn't ask if the patients are civilians or combatants, and in different conflicts and in different settings, it can be really hard to define what the civilian is. If you take, for example, the Kivu conflict, there were children participating in the fighting and also females to some extent. So for this study, I choose to use data from the conflict in Afghanistan and at the border of Afghanistan and Pakistan. Because in this conflict, I know from previous studies that females did not participate in the fighting. So what I did was that from a database of consecutively treated patients in 2009 to 2012, I filtered out the females and compared them to the men with really basic statistics. And what I found was that the females were to a larger extent injured by indiscriminate weapons. And when they arrived at the hospital, they were in worse physiological condition. The blood pressure was altered, the heart rate, etc. And they were subjected to more surgery, more surgical procedures. They had more surgery done to the head, chest, and abdomen compared to the men. So what I think the implications for this study is that if a humanitarian organization or if any surgical healthcare provider is providing healthcare in a conflict, they need to consider the demographics and what kind of weapons that are used in the conflict, because this will reflect what the surgical treatment needs will be. And it will also reflect on what capabilities the hospital needs to have. Okay, so moving on to paper number 2. So for this paper, I wanted to understand how the surgical treatment has evolved over time in this resource-constrained conflict settings. And I choose to focus on extremity injuries. And the reason for this is that there is quite a lot of papers that have demonstrated that in trauma care, the treatment of extremity injuries has improved, so more legs are saved. The functional outcomes are better. And so what I wanted to see if you can see similar trends in these settings. So for this paper, I used the same database from ICR's hospital in Peshawar, but also the sister ICRC hospital in Quetta. And I compared 2 time periods, 2009 to 2012 and 1992-95. So I selected patients from these time periods with extremity injuries and compared the treatments they had received. And in order to do a just statistical analysis, I needed to compensate for things that could disturb the analysis, because I know that the patients in the earlier time period, many of them had injuries from anti-personal mines, but in the later period, that was not the same case. So the weapons that were used in the conflict had changed a bit. So to do this, I used something called Logistic regression analysis. And what I found was that there was actually different in the treatments that the patients had received after adjusting for things like degree of tissue damage, mean arterial pressure, and that kind of thing. There was actually a difference in the treatment they had received. So the use of external fixation, and this is a technique to treat complicated fractures, and also skin grafts had decreased in the later time period. And the risk for amputation was unchanged. And of course, there are could be many potential explanations for why I see these trends, but still it's quite interesting. And I think it's worth exploring further why we don't see the same improvements in these settings, but we see it in trauma settings. So what I'm thinking here is that maybe there are treatment techniques or treatment protocols that are used in trauma settings that can be adopted and put to use in these settings. So moving on to the third study. And so for this study, I wanted to see if there were tools or factors that could be used to predict what the surgical resource consumption would be for patients. And I choose to focus on a scoring system that the International Committee of the Red Cross has used since the 90s, and it's called the Red Cross Wound Score. So this score was developed to be a purely descriptive score, a way to systematically and objectively describe a penetrating injury. And this would facilitate the care so everybody could understand what kind of wound they were dealing with. And I'll go into that in a minute, how you assess the Red Cross Wound Score. And I compared it to two commonly used trauma scores. One is called the Kampala Trauma Score, and this score was designed to be used in low resource settings. And the other one is kind of a golden standard in trauma care, and it's called the Revised Trauma Score. And these scores have been validated to be able to predict mortality, severity of injury, need for admission, and that kind of thing. So I wanted to see which one of these scores were best at predicting surgical resource consumption. So the Red Cross Wound Score is quite simple. You don't need any advanced diagnostics or computers or anything like that. Most of the wounds you can assess by basically looking at them. And what you need to do is that you need to assess the size of the entry wound, the size of the exit wound, and if there is a cavity in the wound, and if there's a fracture, and if any vital organs are injured, like the brain, the lung, the spine. And you end up with a score like this, and in the chart you see it here. And a wound can basically end up in one of 12 different categories. So it's quite a beautiful thing, actually. It's so easy to assess. And what I did here was that I used the same database from ICR's hospital in Peshawar, and also a database from the hospital in the Democratic Republic of the Congo in Goma. And the reason for this was that I wanted to have data from conflicts with different type of injuries and different type of weapons used. And the tricky part with this study was to define what I meant with surgical resource consumption. And I hope we can get back to that in the discussion. And I choose to base my definition on how ICRC defines surgical workload, and adopted after discussing with colleagues of OSA, actually. And to do the analysis in the correct way, so to speak, I used logistic regression models again, and this was to adjust for things that could disturb the analysis. And then to measure the predictive ability of these three scores, I used something that's called receiver operating characteristic curves. And I think you will be pleased with me if I don't go into the statistics that much. So the results were as follows. I actually found that in this material, the Red Cross wound score was actually better at predicting my definition of surgical resource consumption than both Kampala trauma score and revised trauma score. And if I did a little bit of advanced statistics, I could see that the Red Cross wound score actually seems to be better at also predicting in-hospital mortality than Kampala trauma score and revised trauma score. But I think you should interpret that with a great deal of caution. And this finding has some implications, I think. If of course, you need to do prospective studies and all that. But if the Red Cross wound score is a good tool to predict resource consumption, it could be of great use, because there is a lack of valuable measures for outcomes in these settings. And I'll come into that in the next slide. So the recommendations from my thesis on what could be useful for Swedish development assistance are two things. First, I want to mention I don't think that governmental development assistance should go into projects or healthcare that are directly involved in a conflict, in an armed conflict, because that has so many implications that are complicated, and I think we'll get back to that in the discussion. But what I think that the best bang for the buck, so to speak, would be that Swedish development assistance goes to projects that are aiming at or directed at strengthening healthcare system in vulnerable countries. And the word is the resilience of healthcare systems. I think there's much to gain there, and there are many interesting projects that would be good to support. And the second aim, I think, Swedish development assistance should go into is to help in the development of a register for armed conflicts. Currently, the World Health Organization is working on that. And I think that the findings from my third paper, the one about the Red Cross wound score, can be put to use here, that the Red Cross wound score could possibly be a variable that should be collected. Okay, I'll stop there. So thank you for your attention.
Thank you very much, Måns, for the presentation. And I think we all noted what you said about the impact, the clear impact of the ban on landmines in terms of the injuries that were seen in these hospitals that you have worked on and analyzed. And now we will give the mic to Åsa Molde. Please, Åsa, what are your takeaways, your conclusions, your observations from this quite wide sort of spectrum of perspectives in health in armed conflict? Please, Åsa.
Yes, thank you so much for having me. And thank you to all the three presenters. It has been extremely interesting for me to take part of your work and your conclusions and what you propose for the future. I have learned a lot, I must say. I want anyhow to tell a bit more about my background to make clear to you where I come from. I worked many years for the International Committee of the Red Cross, ICRC, so I've actually been working both in Quetta and in Peshawar, which are mentioned in the thesis from Måns. I have probably participated to fill in these data sheets concerning patients So I'm very familiar with this Red Cross wound score classification system. And I'm so happy to hear that you say that it was a beautiful system, because we have had a lot of comments from especially military who think that why do you do this at all? Is it necessary? Is it useful? And I and you, we know, yes, it's extremely useful. Marwan, I didn't meet you before, but I want to tell you that you probably don't know that I worked as a surgeon during the first Intifada in 2002. I worked both in Khan Yunis and I worked in the West Bank, both in Tulkarem, Kalkilya, and in Jenin hospitals. That's a long time ago, but I've been back several times for courses and meetings. Well, and what Signe has been studying, I don't have personal experience, except from my time in Bosnia, where rapes towards women was really a military strategy at that time, where you know maybe that there were camps where women were raped constantly until they got pregnant even. This was a horrible story, but known at the time. And today we see this strategy, if it's a strategy, again repeated in Ukraine. Well, I have listened to your presentation, and of course I'm very impressed by the work you have done, because working in armed conflict and collecting data is not very easy. You have all mentioned the actual problems of working in armed conflict. For example, I mean, the whole situation is unpredictable. It can change anytime. You don't know from one day to another if it's possible to work, if you will get wounded, if you have access, and so on. And you know also that in some areas there are direct attacks on hospitals, on civilians, on hospital staff, on ambulances, which is all forbidden in the Geneva Conventions and other conventions. And we know also that the fighting itself can stop access, that you cannot pass on the roads. The patients cannot come to the hospitals. The staff cannot come to the hospital. It's not possible to transfer any patient, maybe. And you will have limited resources coming. You can be cut off in the hospitals and you cannot get any more supplies. And even food for the patients, which I experienced when I was in Kabul in 92, when everything was cut off. And also in this fighting, electricity supplies can be cut off. And then how do you operate? You cannot really. And if there is no electricity, also water usually is cut off. And then what is extremely important is, in times of conflict, the hospitals might be overcrowded with wounded, which means that normal cases like civilians cannot really be treated. They will not have access. They will not be allowed to enter the hospitals even. And they cannot really go anywhere else. So they stay at home and they will not be treated, and they will wait for a long time and maybe never really have treatment for these non-communicable diseases, Marwan, you were talking about. And it's interesting that all the three of you have mentioned the problems with women in armed conflict. It's very special, of course, in Colombia, definitely. But Mons, it's interesting that you have shown that women might have more injuries due to indiscriminate weapons. And this is really quite new to me. I didn't realize this until I read your thesis. And for Marwan, of course, you have the same problem. Women might not have access when hospitals are overcrowded. I mean, the context you are all describing, they are very different, because you could say that Signe and Mons, you are like visitors coming to this area, and you can make your observations, you can collect statistics, you can talk, you can make interviews. Marwan, you are living in this every day, which is completely different and so much more difficult. So I'm very impressed that you continued your work during these difficult times. And you have done so many interviews, you have collected so many data and put them together in a very important way. So I'm still interested. I mean, I don't know Colombia. But it seems that there are areas where healthcare systems are actually functioning, because it was new to me that it's possible to have a sterilization, because for me, that's the thing you do in hospital, or at least in some kind of clinic. So there must be areas where things are functioning. I'm happy if you tell me more about this. And Måns, you have been looking into well-functioning hospitals, because the ICRC hospitals, they mainly take care of weapon wounded. In Pakistan, they were in safe areas. There was no fighting around the hospital. There could be criminals, but there was no fighting. Kivu was a bit less safe, maybe. But as you said, the indiscriminate weapons like rockets and bombs were not really used in this area. So it was somehow safe. And then it's interesting to say in your conclusions that the Red Cross wound classification system can be used to predict consumption. And in a way, it has been used for this because ICRC created what they called the kits for 100 weapon wounded. Because the experience we have learned is that 100 weapon wounded, there will be some needing an amputation, there will be some with fractured legs, there will be a few with injuries to the abdomen or chest. But if you count for 100 people, you know basically what they will need. So you don't have to look at every individual. So the kits have already been created for ICRC at least, and WHO have similar things. Marwan, you are living in a completely different context, that I said. I mean, you have all the problems with fighting, with access, lack of security, but you are also mentioning something interesting, the lack of motivation among the staff, the lack of training, the missing of guidelines, and also that the non-communicable diseases, they will not really be treated in a good way. Interesting is also when I listen to what you all are saying, that you have some similar proposals, that the healthcare systems must be improved. Well, it's a bit different in the different areas, but there are things to be done. You also mentioned that guidelines should be created to improve quality. Well, we have all worked with guidelines, I think, and we know that guidelines, they also have to be followed, and someone must check that they are followed, which is usually not happening. You also mentioned that proper registration is important, which that's the only way to know the outcome. How is our work functioning? Is it good or bad? But then you have again to create indicators, and someone must check that it's well done. It's very easy to say, okay, guidelines, fine, registration, fine, but it's not that easy. So I have a few questions now. Signe first. I mean, you have very good ideas, and my question to you is, how can they be implemented? We see daily now that the Geneva Conventions are broken. I mean, they are not followed, even by a country that has signed all the Geneva Conventions to promise to keep hospital staff safe, to not attack hospitals and so on. What do you think about Colombia? You mentioned the peace accord, including the rights of women. Do you think it will be followed, Signe?
That's an excellent question. Thank you, Åsa. So first of all, yes, Colombia has indeed ratified the Geneva Conventions, but the case in Colombia is that you have quite a nice set of laws on paper which are not always implemented in practice. So a remaining challenge is to implement the policies already in place to protect women. And for example, you have in the Colombian peace accords goals to implement healthcare, and not least sexual and reproductive healthcare, and to protect people who have been victimized of sexual violence in the context of war. But as I said, it remains a challenge to implement the policies, and it varies quite a lot to what extent the politicians in power are willing to strengthen and bolster the implementation of the peace accord. So even though a lot has happened to really promote SRHR in Colombia in the post-war setting, so to speak, challenges do remain, and the peace process is still ongoing. So it's a little bit too early to say that they have completely finalized and ended the conflict as well, especially since we also see several armed actors taking up weapon and trying to fill the vacuum left by the FARC when they demobilized. So we have actually seen a surge in new conflict violence in Colombia in the post-war moment. So we still have violence challenging both women's safety, but also making it difficult to really implement the policies that are in place. But I know that organizations, both in civil society and the governmental ones that are responsible for implementing the peace accords, do a lot of important and heavy work to really strengthen women's SRHR. So I'm cautiously optimistic that we will see developments in that sense.
And you will follow up on this?
Hopefully, yes.
So Måns, you have very good proposals. I mean, we have to improve surgical care all over the world, more or less, and especially in this thinking that any country can suddenly be in an armed conflict, as we have seen recently. How do we prepare countries to take care of lots of weapon wounded, for example? And what will happen with the civilians in this case?
Thank you, Åsa, for an extremely complicated question. And I don't know if I can answer it at all, but no. I would just like to backtrack a little bit and go to the situation in Sweden right now. I think that to some extent it highlights the problems, but from a completely different angle. So right now we have a huge backlog of patients following the corona pandemic, where we cut down on surgical resources. So if you look at the situation in Sweden, where we have a demand for procedures that needs to be done, but we don't have the resources. So then you have to start prioritizing. So that's one thing, of course, and I mean, you have that in your backbone, how to prioritize patients, who needs surgery first, and what can I do to sustain this person. And then we have the other problem, which is also has come to light now with the unstable situation we have around the Baltic Sea and in Ukraine, which highlights that Sweden and many European countries basically have lost the experience and the capability of handling injuries from armed conflicts. So then you have the part where you need the training. And the third, which is maybe the most complicated, is with logistics, is that if you look at Sweden, for example, we have just-in-time delivery, and it doesn't even work in peacetime. So these are the set of problems we have in these high-resource settings where we have abundance of resources. And then if you go to and this is really the minority situation in the world. And then you go to low-income and middle-income countries where you don't have any logistics at all, basically, and the trading system is non-existent. In some ways, this is more of an experience driven. They have the experience of war injuries, so maybe that would be a good starting point. That these countries have the experience, but they need the support to have a functioning logistical system, and maybe that's something that governmental organizations from high resource countries can provide. And then you need to. I want to come back to, because I think that's the most important finding of my thesis, is that you need to be sure that you're using the resources in a proper way to maximize the outcome for the patients. I don't think that was an answer to your question. Maybe I just complicated it a little bit more, but these are some of the aspects of this question you asked me.
Well, thank you. No, it was complicated, but the whole situation is complicated. And being prepared for an armed conflict or a pandemic, we have seen is not very easy, actually. Well, Marwan.
I would like to add there that guidelines are really nice. They're beautiful to have. They're beautiful to have at my hospital. They're beautiful to have when I worked in Congo Brazzaville. But that's not the solution to this problem. The problem of creating resilient healthcare systems is the solution lies in creating the stable backbone of the organization, that you have the surgical capabilities, you have the logistical capabilities, and you have a safe environment for the hospital staff to work in.
Yeah, and this you can have in our countries like ours, but a bit more difficult maybe in the east of Congo. Yeah, and even in Gaza, I think it is very difficult on the daily side. I mean, Marwan, yeah, so you have really so many problems. You have listed them all, and you have so many proposals also to what needs to be done. My question to you is, where would you like to start?
Thank you so much. You know that, as you said, we have never been met before, but today I am happy to hear that you were working in the Gaza and Khan Yunis and in the West Bank and Kalkilia, Tul Karim, and so on. But I hope that we will benefit from your experience in this field. You know that in Gaza we have had a lot of challenges and restrictions, because you know that the origin and root of the problem is political, and this is not so easy to be fixed, because you know that in the Gaza Strip we have been under the siege blockage since more than 16 years, and you know that restriction and referral of patients, movement restrictions, a lot of checkpoint from the Israeli occupations. There's a frequently cut of electricity. The medication is frequently cut out, and the resources is very limited. And the micro specialties are limited, like for example neurosurgery specialties, vascular specialties, surgeries, cervical spine surgeries, and the installments of procedures and the tools, I mean the surgicals and operations are not well occupied, and we have a lot of problems. And I think without international commitment and support, especially for the political problems, I think the problem, I am sorry to say, that will continue. You mean that the problem in Palestine, in the Gaza Strip and the West Bank since more than 70 years. You know that the occupation since 1948, you know. So I mean that I think that the problem can be resolved with the minimum level from the assistance of the international community. I mean that support in medical field and surgical installment, and you know that the hospitals doesn't work as they should be, because you know that a lot of things we need in the hospitals, in operations room, and in for example renal dialysis, you know the heart surgeries, and a lot of things we need in the Gaza Strip. And you know that we need the assistance from the WHO to create and to adapt and updated guidelines to be followed in the hospitals. That's very important and very necessary to improve the healthcare in the Palestine. That also the key resources are necessary. That a lot of things that we need there. Beside the political solution, that we need to implement the international resolutions, but this is very, very, very difficult. We are not going to talk about them because this is not our discussion right now. But we let this problem to be discussed by the politicians. But now we will focus on the healthy problems regarding the medical resources, the micro specialties to be supported, and adaptation of the guidelines. But that the Palestinian Authority is not able to adopt all of these or to fix all of these problems alone. That this is very, very complicated.
Yeah, so thank you, Marwan. We know that it is complicated. Johan, will you take over to lead the discussion, or if there are other questions?
Yes. Thank you very much, Åsa, for asking questions sort of that emerge straight out of your own personal experience of these kinds of contexts. Very interesting, very relevant discussion. That maybe the three of you have listened to each other. You may have any comment or any question to any of your colleagues. But before inviting you to do that, I'd like to ask one question of Marwan, namely the burden of mental ill health, which is prevalent, of course, in these kinds of contexts. And I've seen data on the very high incidence of clinical depression, for example, in Palestine.
Yes.
Do you see that also as part of the pattern of non-communicable diseases in this specific context?
Yeah, this is a major problem in Palestine, especially in the Gaza Strip, because that the people in the Gaza Strip, especially children, are exposed to frequent wars and violence in the Gaza Strip. That huge, they face huge wars in 2008, 2012, and 2014, and 2020. If you go to the international data by human rights, you will see that the prevalence of depression and mental problems are very, very high, and this needs to be fixed by the institutions who are working in this field, and this is need further research to be addressed. This is not easy.
Yeah. No, thank you. I think this is important. We're trying to take a sort of holistic perspective here. So this is one element that is.
Of course.
Would anyone of you like to ask any of your colleagues anything? Any burning?
I would be happy to ask a question to Signe.
Please.
I was really fascinated by your presentation, and I got a lot of ideas in my head. And the first question is basically kind of simple and comes back to what Åsa asked you. So say that we have a situation of an armed conflict, and Åsa and I are working there as surgeons at a hospital. How should we deal with women reproductive health? Should we do sterilization in between while we're treating weapon-related injuries, or should we put that on hold? How should we deal with it as surgeons or as hospital staff?
Thank you. That's a very interesting and relevant question, I feel. So first, to back up a little bit, since Åsa did pose a question for me about sort of how can we expect sterilization to even be accessible in the context of conflict? So first of all, I'd like to say that Colombia is considered overall a success case when it comes to family planning programs. So you have family programs dating back to the 1960s, as well as in the context of conflict. So family planning programs have really developed within the context of war. And I think that speaks to a little bit of how the healthcare system in Colombia may be more robust compared to other settings where you have more intense conflicts going on. So Colombia is a low intense conflict and it's a middle income country. So we might see a more robust healthcare system than, for example, in DRC or Palestine. I also find from my interviews that it's probably easier for women who want to access family planning programs to just visit a healthcare facility once to sterilize, as opposed to making regular visits to access more short-term reversible contraception. So it might be difficult to rely on, for example, condoms or the pill or something like that if you don't know when medical shipments will arrive next time, or pharmacy shipments. So that's a reason, I think, why sterilization became such a commonly used method in Colombia and also increased in relation to conflict. And it does seem like sterilizations are readily available in Colombia, even in parts of more intense conflict zones, which also speaks, I think, to the robustness of the healthcare system. And when coming back then to your question, Mons, I think that the most important thing from a sexual and reproductive health and rights perspective is to ensure that women do have access to the methods that they prefer and that they want to have. But as surgeons, if women find that I can't access more reversible methods, more short-term methods, and I want to make sure that I don't have any unwanted pregnancies, then of course sterilization is sort of a risk aversion option for them. And then of course it would be good if women can access the services of sterilization.
Thank you. Yes, thank you, Signe. Any other question from any of you? Or we could go, there are a few questions from our spectators and listeners, one of which is, again, for Signe, given the constraints and so on that you present in terms of access to SRHR services, who are those who actually do provide these services? Obviously, the government to some extent, but there are also other actors. Could you say a bit? And you refer to organizations in your thesis. Could you say a few words about that?
Absolutely, yes. So we do have, of course, public healthcare providers, but when it comes to a lot of sexual and reproductive healthcare services, actually a lot of them are performed by private healthcare providers. So you might think of the IPPF association member, Pro Familia. It is the largest provider of family planning, contraception, information, sexual education in schools, and so on. So a lot of the heavy lifting when it comes to provision comes from the private sector. And they also have had a mobile clinics system, which has been used to make sure that services can be accessed even in the remote parts of the country where the state presence has traditionally been low and also might be more affected by armed conflict. And these private healthcare providers could actually go to the regions where armed actors control the area to provide healthcare services, precisely because they were private providers and weren't suspected of, for instance, collecting information for the state. But those private providers were often let into those areas in exchange for also providing sexual and reproductive healthcare to the guerrilla soldiers. So if we think about the FARC guerrilla, 1/3 of the recruits in the FARC guerrilla were women. And of course, childbearing isn't really something that FARC wanted for their female recruits, because it would hinder their female recruits from participating in fighting. So we have observed systematic practices of forced family planning, abortion, and adoption among the female recruits in FARC. And I wouldn't say that the private healthcare providers have been should be held responsible for that, but at least they were able to enter some FARC-controlled areas to provide services, precisely because the FARC wanted contraceptive goods and services provided for their female recruits.
Thank you. Can I ask a related question of Marwan? Given you've presented the sort of limited or lack of confidence that the public has in the health services system, what role is there in terms of private health providers, particularly in Gaza? Do people seek other kinds of services or service providers?
Regarding the private sector in the Gaza Strip, you mean that in the Gaza Strip, you know that not all people are able to enroll or receive the care from the private sector. You know that the private sector is very expensive, and the poverty in the Gaza is very prevalent and very high, and not all people have the right to receive the care from there. This is a big problem also, beside the limited resources in the governmental hospitals. Yeah, really is very, very, very problematic in the Gaza Strip.
Yes, so many challenges, many burdens, and I think it's important. Exactly. What you pointed out, that there's a political context to all of this, and we cannot ignore that, even if we now have to focus on the health services, the health system, and so on. There is this unique and extremely difficult political context that cannot be ignored.
Okay, you know that the UNRWA, I mean the United Nations, Hello?
Yes, please.
You know that the UNRWA, the United Nations, have the basic provider in the health system, in the Palestinian health system. But you know the UNRWA are not providing all the care. You know that their services focused only on the primary services like vaccination, following non-communicable diseases like blood pressure, heart diseases, but they are not providing the secondary care. You know that this is also problematic in the Gaza Strip.
Yes. We are approaching the end, and I'm going to conclude in a minute, but I'll give each one of you 15 seconds if there's any final message that you want to convey, and so that the audience, when they turn off, that they should remember after this session. Please, Signe, would you like to begin?
Yes, thank you. So I think that this panel has shown in a very nice way how the importance to consider healthcare provision in the context of conflict, and I just hope that this panel and similar efforts will help enlighten policymakers, and I'm glad that we have had a chance to discuss this issue, because it's very important and sometimes not given the attention that it deserves. So thank you.
Thank you, Signe. Marwan, your 15 seconds.
Yes, thank you so much for this opportunity. You know that in the Gaza Strip, we need additional support to enhance the health system, and we need to improve the collaboration between the different stakeholders, the private and international stakeholders. Thank you so much.
Thanks, Marwan. And Mons, finally.
Yes, I would like to what I think has been discussed a bit during this seminar, that the importance of strengthening healthcare systems in other parts of the world is beneficial also for us. We can learn a lot on how they approach different problems, and I think this could have implications for how we conduct healthcare in Sweden, especially surgical healthcare. So this is, for me, this is a win-win situation, engaging in projects to strengthen healthcare in low-resource settings.
Thank you very much, Måns. And one final reflection from the perspective of us, of EBA. I think one can say that many of the activities that you have described would fall within the humanitarian sector and will be performed by humanitarian actors. But of course, the systems that you talk about that are needed, the health systems, they are very much a development concern. So this is an area, again, where you cannot move forward without sort of walking on these two legs. There's a humanitarian and a development leg, very clearly. So thank you so much, Signe, Marwan, Måns, and thank you specifically to Åsa for your comments and your very thoughtful considerations of this. Let me conclude by announcing that for future seminars, you can go to our website, www.eba.se, and sign up to our newsletter and look for updates on coming events and also reports that are being published. The next seminar will be already next week on the 11th of May, and we will then present an evaluation of the Folke Bernadotte Academy. I think this is going to be really interesting. Please also note that we have a podcast where we, in a more light and sort of short way, reflect on the themes that we present and work on. You'll find that link also on our website. And finally, thank you all for your participation in today's seminar. Have a very good day and goodbye from us.